Imagine walking into a doctor's office, like just in absolute breathtaking agony, and you walk out with a prescription to, just try to relax a little more.
Oh, yeah. The classic, it's all in your head response.
Right. You explain that every single time you experience deep penetration during intimacy, it feels like this literal collision inside your body.
Mm.
And the response you get is just this sympathetic nod and a suggestion that maybe you have a psychological barrier.
I mean, it's honestly one of the most frustrating experiences a patient can endure. Being told that a very acute, very physical sensation is somehow entirely your fault or your anxiety.
It's gaslighting.
It is profound gaslighting. Because as a patient, you absolutely know what a mechanical injury feels like. I mean, if you drop a heavy weight on your foot, you don't need a medical degree to understand the physics of why that hurts,
No,
right?
it does exactly. Two solid objects collided. Boom. Pain.
Right. But when you step into the world of chronic pelvic pain, suddenly those basic laws of physics just get tossed out the window, and patients are left in this incredibly murky diagnostic landscape.
Which is wild. But what's so fascinating and frankly so validating about the stack of medical literature we're looking at today is that the physics of this specific pain are just as real and just as mechanical as dropping that weight on your foot.
Absolutely. The collision is just happening deep inside the pelvis, completely out of sight.
Yeah. And that brings us to the exact mission for today's deep dive. We've pulled together clinical studies on dyspareunia, which is the medical term for painful sex, alongside obstetrics guidelines and some, frankly, incredibly dense pelvic anatomy texts.
Very dense.
So dense. But okay, let's unpack this. Our goal today is to shine a massive floodlight into those muddy waters. We're going to unpack exactly why a severely retroverted or tilted uterus causes sharp, intense collision pain during deep thrusting.
And we really want to map out the deep ligamentous tension pathways that actually trigger that pain. Because if you've ever experienced this, or, if you have a partner who has, this isn't going to be just some dry anatomy lesson.
Right. It's about proving a physical reality.
Exactly, because when you finally understand the biomechanics at play here, the whole idea that this could ever be cured by just relaxing becomes completely absurd.
So absurd. So let's jump right into the baseline anatomy, because everything kind of hinges on how the internal furniture is arranged down there.
The internal furniture, I like that.
Right. So about 20% of women, so like 1 in 5, have what is called a retroverted uterus. And the sources say it's considered a natural anatomical variant, not necessarily a disease. But how exactly does that alter the standard pelvic layout?
Well, to really grasp the difference, you have to picture the typical alignment first. So usually a uterus is what we call anteverted.
Anteverted, okay.
Yeah, so imagine the uterus leaning forward, tilting over the bladder, almost as if it's just resting gently right on top of it. It points toward the front of the belly.
Leaning forward, got it.
But in that 20% of women with a retroverted uterus, the entire organ tips backward. The top of the uterus, the fundus, is aimed completely away from the bladder.
So it's pointing backward toward the spine.
Exactly. It points backward toward the rectum and the hollow of the sacrum, which is essentially the inside of your tailbone area.
Okay, so instead of tilting comfortably over the bladder in the front, it's tipping backward, sort of looming over the spine.
Right. And under normal, everyday circumstances, going to the grocery store, walking around, this backward tilt doesn't usually cause any major red flags.
But things change completely during intimacy.
They change completely. And to understand why, we really have to look at some foundational data from Masters and Johnson regarding the actual physiology of arousal.
Yeah, I found this part of the reading so interesting.
It is. This is where the structural engineering gets really fascinating. Masters and Johnson were pioneers because they documented the physical, real-time shifts that happen internally during sexual response.
It's like the body physically rearranges itself.
It literally reorganizes itself to accommodate penetration. It's a profound structural shift. During normal arousal, the upper end of the vagina lengthens significantly by about 3 to 4 centimeters.
Wow, that's a lot.
It is, and it widens to an overall width of around 6 centimeters.
So the body is actively creating space. It's expanding the room. But how that expansion happens seems to depend entirely on which way the uterus was tilting to begin with, right?
That is the exact point of biomechanical divergence. When a woman has a typical anteverted uterus, the one leaning forward, that natural arousal response causes the entire uterus to elevate.
Elevate, so it moves up.
Yeah, it moves in a cephalad direction, which is just a fancy medical way of saying it pulls up in a way toward the head.
Okay, making room.
Exactly. By lifting up, it pulls the cervix, which is highly sensitive, entirely out of the direct line of penetration. It essentially creates a safe, elongated, unobstructed vaginal barrel.
I was trying to picture this earlier while reading the sources. It's kind of like a drawbridge lifting up to let a tall ship pass safely underneath,
Right.
right? Like it moves all those delicate structures entirely out of the path of oncoming traffic.
That's a really helpful visual, but it's actually even more precarious than a simple drawbridge. Yeah, because a drawbridge just blocks the path if it's down. In the case of a retroverted uterus, the body is still trying to expand and make space, but the geometry forces it to happen incorrectly.
Because it's starting from the wrong angle.
Right. Because the uterus is already tilted backward, it physically cannot lift up and away toward the head. So instead, the vaginal expansion happens more anteriorly between the bladder and the uterus.
So the drawbridge opens the completely wrong way.
Exactly.
It doesn't lift out of the path, it just kind of shifts the angle, leaving the cervix sitting right in the direct line of fire.
Precisely. It leaves the cervix fully exposed at the very end of the vaginal canal. It presents a direct, unavoidable mechanical obstacle for deep penetration.
But wait, let me push back on this for a second because the math is just kind of glaring at me.
Okay, go for it.
If 20% of women have a naturally retroverted uterus, why isn't every single one of them experiencing this agonizing pain during sex? Like, 1 in 5 women are showing up at the doctor for this specific breathtaking agony.
It's a crucial question, and it's where the clinical data draws a very hard line. Having a retroverted uterus is the prerequisite for this specific type of collision pain, but it is not the only factor.
Okay, so what else is at play?
Well, the severity of the geometry matters immensely. First, you have to consider the degree of the tilt. Like, is it slightly backward or is it severely folded back against the rectum?
Okay.
Second, what is the depth and angle of the physical penetration itself? But the most critical variable, the one that really dictates the pain level, is mobility versus fixation.
Fixation meaning like the organ is literally stuck in place.
Yes. A healthy retroverted uterus, even if it's pointing backward, is usually pretty mobile. It has some give.
Like a shock absorber.
Right. If it gets bumped during intercourse, it can shift slightly out of the way, absorbing the impact safely. But if there are other complicating factors in the pelvis, it loses that mobility entirely.
What kind of factors?
Think about pelvic adhesions from a previous surgery or endometriosis.
Endo, yeah.
Yeah. Endometriosis is a condition where tissue similar to the lining of the uterus grows outside of it. It causes intense inflammation and leaves behind dense, sticky scar tissue.
And that tissue traps it.
It can literally act like superglue inside the pelvis. It can grab hold of a retroverted uterus and lock it rigidly into place, tethering it to the pelvic floor or the bowel.
Oh, wow. So it's literally glued down.
It is firmly anchored. So now when it gets struck, it has absolutely nowhere to shift. There's no give. It absorbs the entire mechanical force of the impact.
Which brings us directly to the medical phenomenon at the center of this deep dive. The clinical term the sources use is collision dyspareunia.
Yes, collision dyspareunia.
And the definition is highly specific. It describes a deep pain felt intensely inside the vagina, deep in the pelvis, or radiating through the lower abdomen that is elicited specifically and immediately by penile thrusting.
And the mechanics of this strike trigger a literal chain reaction inside the body. Let's walk through the physics of the actual moment of impact.
Walk me through it.
So, during deep penetration, the penis strikes the exposed cervix. Because this retroverted uterus is severely tilted backward and potentially glued in place, that physical strike forcefully rams the entire heavy body of the uterus further backward.
Into the tailbone area.
Right. It gets shoved directly into the hollow of the sacrum.
It's not just bumping into empty space, it's being rammed into the skeletal structure of the spine.
Exactly.
But the uterus doesn't just float freely in the pelvis, right?
Yeah.
There have to be support structures holding it. What is actually taking the brunt of this force?
That is where we have to talk about the deep ligamentous tension pathways. The primary anchors holding the back of the cervix and the upper vagina in place are called the uterosacral ligaments.
The uterosacral ligament.
Yes, and these are incredibly dense, strong bands of connective tissue. They run from the cervix and attach directly to the presacral fascia, which is the tough tissue covering the sacrum, right at the level of the second and third sacral vertebrae, S2 and S3.
So they are anchoring the uterus directly to the lower spine.
Exactly. And if we connect this to the bigger picture, you have to realize that these uterosacral ligaments aren't just passive slack ropes loosely tying things down.
Right.
They are vital, highly dynamic support structures. So when the cervix is violently struck and that heavy uterus is forcefully jolted backward into the sacral hollow, those uterosacral ligaments are subjected to immense sudden stretching.
It's like someone grabbing the heavily tensioned anchor ropes of a massive canvas tent and just yanking on them with their full body weight.
Yeah.
Repeatedly.
That is a very accurate way to describe the mechanical strain. You have the blunt force trauma of the uterus physically hitting the sacral hollow, combined with the extreme mechanical tension of those uterosacral ligaments being stretched to their absolute physical limit.
But this is where I get a bit confused, honestly.
Okay, what's confusing?
Well, I understand that stretching a ligament hurts. If I roll my ankle and stretch a ligament, it throbs. But a stretched ligament alone doesn't seem to fully explain the sheer, blinding, I need to stop right now, intensity of the pain these patients report in the clinical studies.
That makes sense.
Right, like the mechanical tension makes sense, but the volume of the pain seems totally disproportionate. What are we missing here?
We are missing the electrical engineering.
Mhm.
Yeah, to understand the volume of the pain, you have to look at the neurological payload of those structures. This isn't just about structural engineering, it's about what happens when you aggressively manipulate the primary nerve centers of the pelvis.
Okay, where are the nerves in this equation?
Remember that hollow of the sacrum? The exact spot where the retroverted uterus is being forcefully rammed into.
Yeah.
That is not an empty, padded space. It is home to something called the inferior hypogastric plexus, or the IHP.
Oh, the IHP. I remember the anatomical text referred to it as the major neuronal integrative center of the pelvis.
Yes. Think of it as a massive, highly complex neurological junction box. It's a dense web of autonomic nerves situated right in the presacral tissue on either side of the rectum.
Which is exactly where the impact is happening.
Exactly. And the IHP is responsible for controlling the bladder, the lower intestines, the reproductive organs. It regulates blood flow, smooth muscle contraction, and pain signaling for the entire lower half of the torso.
So if the IHP is a massive neurological junction box, the hollow of the sacrum is essentially a highly sensitive, completely exposed circuit board.
That's it, exact.
And during collision dyspareunia, every single deep thrust is forcefully hammering a heavy, rigid uterus directly into that live circuit board.
That is exactly what is happening. The blunt force trauma is a direct strike to the IHP, but it's actually a two-front neurological assault.
A two-front assault.
Yes, because those uterosacral ligaments we discussed earlier, the anchor ropes of the tent, they don't just hold the uterus in place, they serve as structural cable conduits.
Wait, the nerves are inside the ligaments.
Yes, the nerve fibers from the IHP travel directly inside and along those uterosacral ligaments to reach the uterus and cervix. And these aren't just any nerves. Many of them are unmyelinated nerve fibers.
Unmyelinated meaning they don't have insulation.
Correct. They lack a protective myelin sheath. This makes them incredibly, exquisitely sensitive to physical tension and mechanical pressure.
Oh, wow.
So when that uterus is jolted backward and you violently yank on the uterosacral ligaments, you aren't just stretching connective tissue. You are mechanically stretching live, uninsulated nerve fibers to their absolute breaking point.
That sounds horrific.
Right.
So you have a heavy organ bruising the main circuit board while simultaneously stretching the uninsulated cables running out of it.
Exactly.
It's just a neurological nightmare, perfectly engineered by bad internal geometry. And the clinical studies mention that this dual mechanism creates two very distinct, recognizable types of pain for the patient. Can you explain why it feels so different depending on the pathway?
Yeah, so it comes down to where the signals are originating and how they travel. The inferior hypogastric plexus is actually a meeting point for two different branches of the nervous system.
Yeah.
You have sympathetic fibers, which originate higher up, traveling down from the thoracolumbar segments of the spinal cord, essentially the middle of your back. And then you have parasympathetic fibers, which emerge from the pelvic splanchnic nerves right there at the sacrum, levels S2 to S4.
And the brain translates those two signals differently.
Very differently. When those unmyelinated nerve fibers inside the uterosacral ligaments are stretched by the sheer weight and violent movement of the uterus, that mechanical tension registers primarily through the sympathetic pathways.
Okay, and what does that feel like?
The brain interprets this as a profound, deep, visceral dragging sensation. Patients will often describe a heavy, sickening, aching drag deep in their lower pelvis that just kind of radiates into their lower back.
That's the feeling of the cables being stretched.
Exactly. But then you have the direct physical collision. When the cervix is struck and the uterus violently smashes into the main body of the IHP serpent and the sacrum, that triggers the parasympathetic pathways.
And that's the sharp pain.
Right. That registers as a sharp, acute, breathless stabbing pain.
So it's a heavy, sickening drag combined with a sharp, stabbing breathlessness. And because the IHP is the control center for everything down there, I'd imagine the pain doesn't just stay neatly confined to the uterus, right?
It absolutely doesn't, because the IHP integrates signals for the bladder and the bowel. Trauma to this plexus causes neurological crosstalk.
Like the signals get crossed.
Exactly. The brain gets overwhelmed by the alarm bells. This is why a patient experiencing collision dyspareunia might suddenly have severe bladder spasms, sharp rectal pain, or a lingering, throbbing postcoital ache that can last for hours or even days after the physical collision has stopped.
That is wild. The nervous system is essentially short-circuiting,
It really is.
which makes the advice patients are given even more critical. And this brings us to a really fascinating and frankly confusing contradiction I noticed when reading through the clinical advice in the sources.
Ah, yes.
Uh,
The position advice.
right. It's about sexual positions. One source, the Better Health Channel, explicitly warns that the woman on top position usually causes the most severe pain for a retroverted uterus because of the angle of the collision.
Right.
But then you read the UB doctor's note, and they strongly suggest that the woman on top position can significantly reduce discomfort. So, looking at the physics we just mapped out, who is right? Is it the best position or the absolute worst?
It seems like a glaring medical contradiction, but it actually synthesizes perfectly when you apply the exact biomechanics we just discussed. It all comes down to a physiological battle between control and gravity.
Walk me through that. How does control factor in?
So the UB doctor's note is focusing heavily on control. In the woman on top position, the receiving partner has total autonomous control over the depth, the speed, and the angle of penetration.
Right, they can dictate the movement.
Yes. By carefully managing that angle, they can consciously guide penetration anteriorly toward the front, completely avoiding the exposed cervix. In that highly controlled scenario, the position is incredibly protective.
You essentially steer the ship carefully away from the broken drawbridge entirely.
Exactly. You are avoiding the trigger mechanism. But the Better Health Channel is looking at what happens if that control slips, and they are factoring in the sheer physics of gravity.
Oh,
If, in that same position, the partner does allow deep penetration, the dynamic changes catastrophically.
because gravity is pulling the heavy uterus down.
Yes. With the woman on top, gravity is actively pulling the full weight of the retroverted uterus downward, deeper into the pelvic floor. When a forceful upward thrust meets the downward gravitational pull of that heavy organ, the collision is magnified.
It's literally a head-on collision.
There is absolutely no give. The uterosacral ligaments take maximum violent tension, and the IHP circuit board takes maximum physical impact. So it requires strict vigilant control to be beneficial. Otherwise, gravity makes it the most mechanically destructive and painful option available.
That makes complete sense. It's a high-risk, high-reward position mechanically. So what happens if positional changes just aren't enough? Like, what if someone has that severely fixed, glued-down retroverted uterus we talked about earlier, and every single angle triggers that dragging and stabbing pain?
It's a tough situation.
The clinical guidelines do mention surgical and mechanical interventions.
They do. When conservative measures fail and a doctor has ruled out other conditions like an active pelvic infection or large ovarian cysts, the primary surgical option highlighted in the literature is a procedure called a hysteropexy.
Hysteropexy. It sounds like an anatomical remodel. What are they actually doing in there?
That's a great way to put it. It is a structural remodel. A hysteropexy is a surgical correction of the uterine axis. The surgeon goes in, carefully cuts away any of the endometrial scar tissue or adhesions that are gluing the uterus down to the bowel, basically freeing it up.
Okay.
Then they physically shorten and reinforce the supportive ligaments, pulling the uterus forward and securing it into a standard forward-leaning anteverted position.
They literally pull the drawbridge back over the bladder where it belongs and lock it in place.
Just like.
And the clinical outcomes on this are wild. The data shows that for pure collision dyspareunia, where the pain is strictly originating from this mechanical strike against the IHP, a hysteropexy boasts a greater than 90% success rate in eliminating the pain.
It's incredible.
90%. I mean, if anything proves that this pain isn't all in your head, it's the fact that surgically altering the physical geometry cures it almost completely.
It is entirely undeniably mechanical, which, honestly, this raises an important question that patients often ask. How did the internal geometry get so severely altered and fixed in the first place?
Right.
We established earlier that 20% of women are just born with a natural backward tilt. But our sources highlight that in a significant number of the most painful fixed cases, the retroversion was actually acquired later in life. It wasn't always pointing backward.
The anatomy was physically altered over time. And the literature points to a few main culprits. I mean, we already touched on endometriosis leaving behind that sticky scar tissue. But the second major culprit completely blew my mind when I read it.
I know what you're going to say.
Obstetric trauma, specifically cesarean sections.
Yes. A C-section isn't just a delivery method. It is a major abdominal surgery that can permanently alter the structural integrity and geometry of the pelvis.
But how does that happen? A baby is delivered, the uterus is stitched up. Why does it change direction?
The clinical data includes some fascinating retrospective observational studies on postpartum uterine positions. They found that a C-section inherently creates a scar defect in the lower segment of the uterus.
Okay, a scar firms.
Right. And as the body heals from the surgery, that scar tissue naturally contracts and tightens. Because of where the incision is typically made, that contracting scar tension can act like a rigid mechanical tether.
Wow.
Over time, as it shrinks, it physically pulls a once forward-leaning anteverted uterus backward, dragging it into a severely retroflex position.
That is incredible. The surgery, meant to safely deliver a child, inadvertently engineers a long-term structural hazard. The healing process literally shrinks and pulls the organ out of its natural alignment.
And because it's now heavily tethered by dense surgical scar tissue, it loses all of that natural healthy mobility we talked about earlier.
Right, the shock absorption is gone.
Exactly. It can't shift out of the way anymore. It becomes a fixed, rigid target permanently positioned directly over the sacral circuit board.
Wow. So, if you've been listening to this deep dive and mapping these symptoms onto your own experience or a partner's experience, you really need to internalize this. It is not a psychological issue.
Not at all.
It is not an emotional failure to relax. It is a highly specific, structurally engineered biomechanical event. You are dealing with a physical collision involving the weight of your uterus, the extreme mechanical stretching of the unmyelinated nerves inside your uterosacral ligaments, and the direct bruising of a massive neurological junction box called the inferior hypogastric plexus.
Very well said.
Thank you. It is pure physics, it is measurable anatomy, and your pain is entirely real.
And knowing the physical mechanics is the very first step toward advocating for yourself. It empowers you to seek the right kind of specialized pelvic floor therapy, or to have a really informed conversation with a surgeon about mechanical interventions.
Absolutely.
But I want to leave you with one final thought to mull over, building on exactly what we just discussed regarding acquired retroversion and childbirth.
Ooh, I love a good lingering question. Lay it on us.
We know from physiological data that during pregnancy, the body releases hormones like relaxin, which naturally depolymerize and chemically relax all the pelvic ligaments, making everything looser and more pliable for birth.
Right, getting ready for the baby.
Exactly. We also just explored the clinical reality that C-sections can mechanically pull a uterus backward into a fixed retroverted position via the tension of contracting scar tissue.
Okay, I see where you're going with this.
When you synthesize those two facts together, you really have to wonder, how many women out there are silently living with sudden onset collision dyspareunia postpartum?
Wow.
How many mothers mistakenly believe that their bodies are simply broken, or that their pain is just a psychological failure to bounce back after having a baby?
That's heartbreaking.
It is, when in reality, the combination of pregnancy hormones relaxing their structural anchors and surgical scar tissue tethering their anatomy has subtly but completely re-engineered their internal geometry. They are unknowingly living with a uterus that has been permanently pulled backward, putting their uterosacral ligaments on a direct, unavoidable neurological collision course.
It fundamentally changes how you view postpartum recovery, doesn't it?
It really does.
I mean, just because the body's internal drawbridge is hidden deep in the dark, muddy waters of the pelvis doesn't mean the crash isn't happening. And it certainly doesn't mean it's all in your head. Thanks for taking this deep dive with us. We'll see you next time.